Go back one. All right, so here we are. Welcome to the virtual forum on the hospital-based child and adolescent psychiatric care in the setting of COVID-19 pandemic. I hope you're in the right session. There are lots of sessions going around, but this is our very first at AACAP. This is sponsored by the American Academy of Child and Adolescent Psychiatry, Emergency Child Psychiatry Committee, Inpatient and Partial Hospitalization Committee, and the Physically Ill Child Committee. And we have special thanks to Vera Foyer and Nasu Malas, who are the ones who really put this forward as an idea, and Dr. Gay Carlson for helping us get AACAP support to do this forum with you. So we're very excited. Our moderators today are going to be Patrick Kelly, who's the co-director of the Child and Adolescent Psychiatric Emergency Unit and co-director of the Child and Adolescent Consult Service at UCLA, and myself, Marilyn Powell. I'm the clinical director and deputy scientific director at the National Institute of Mental Health and NIH in Bethesda, Maryland. Our objectives today have been posted to you when you signed in, and really we're just here to discuss the anticipated and unanticipated challenges in the pediatric hospital-based response to COVID-19, as well as lessons that people have learned across the United States in our various institutions. We hope sharing them will inform you and how we shape our future response to this pandemic.
So what we're going to cover today includes the introduction that we just had from Maryland. We're going to be fortunate enough to have an address from the current AACAP president, Dr. Gabrielle Carlson. And then we're going to go through a few domains of response to the COVID crisis, including administrative issues in staffing, clinical service delivery, training and education, and staff stress response and psychological trauma. After each presentation, there will be time for questions and for discussion, as well as a larger wrap up at the end of the presentation in its entirety. So this is a webinar. Everyone will be silenced for the webinar. If you have questions that you want to ask, please submit them to the question box. Due to time limitations, not every question will have a chance to be answered, but we'll try to get through as many as we possibly can. And after the webinar is completed, there will be a posting of this recording. Now I'd like to turn it over to Dr. Gabrielle Carlson, the president of our organization of AACAP.
Good afternoon, everybody. Nice to be spending the Saturday afternoon with you. I don't know about you guys, but I'm not sure I even know the difference between a Monday, Tuesday, Wednesday, Thursday, Friday, or Saturday anymore. I will just try to limit my remarks and try to keep my foot out of my mouth for the next few minutes. If we could have the first slide. Okay. So we all know what the coronavirus has taken away from us. I sort of think about it as a bowling ball that has just basically knocked over all of our 9 pins or 10 pins and has taken away a variety of things. We can't visit people in hospitals. We can't go shopping. We can't get together with loved ones. We can't even have drop-by conversations with people like when you see them in the supermarket. We can't go to concerts, plays, restaurants, or sporting events. We've lost part of our clothing in the stock market. Jobs have been lost by the droves. We can't travel. We can't hold weddings or funerals to the extent that we would like to. And of course, it's hampered our students going to school and college. It's hard to put a good blush on this. One of the things that we try to do when we cope is to be in control of the things that we can be in control of. So I just thought I would remind you of some of the things that AACAP is doing to help. One of them is to have a forum like this one. This really is a stroke of genius on the part of the committees that have taken part in it. You'll see that the content is going to be really exciting. There are a number of other forums that are going on. Vera Foyer, one of the brains behind this one, has organized one for the New York Council, for the ROCAP for New York, and they have theirs on Thursday night. There are other opportunities like that that are going on. I've developed something that I call the Screenside Chats. My first one was on improvised telepsychiatry, and I interviewed David Roth from the University of Hawaii. Yesterday, I interviewed Jim Hujak, who, as you know, is a great proponent of health promotion and illness prevention, and he talks about how to do this remotely. They have a fantastic website that you'd want to know about. Speaking of websites, if you haven't checked out our website, the AACAP website, please do that. We've got some outstanding coronavirus resources. There are resources for families and for clinicians. Mentorship continues to be a strong suit of ours. We help our trainees and younger early career child psychiatrists. We're a community of colleagues. I think more than ever, we are depending on each other for information and for just simply having camaraderie. Our ROCAPs and listservs are a really great source of keeping in touch with each other and learning from each other. In fact, the listservs, there are a couple of listservs that have supported this virtual forum. We've got some wonderful online education through Pathways. We are about 2/3 of the way through the Hansen Review and Update course. And for those of you who've missed that, that's going to be made available to you again through our Pathways a learning management system, and that's covering topics like vaping and motivational interviewing and gaming and social media and disaster and trauma and suicide, managing suicidal behavior and school threats. Anyway, a wonderful list of topics. Our advocacy component is strong and is growing. It is enormously important that we continue to have a voice in our government and with our community locally, statewide, and nationally. And finally, for us, AACAP is our professional home. I don't know how many of you were privileged to watch the CNN Sesame Street broadcast this morning that went on for about an hour and a half, where the Sesame Street puppets and Sanjay Gupta and a couple of other people were fielding questions from kids. And our own Wanjiku Nuroji was capably able to represent child and adolescent psychiatry and AACAP in that broadcast. And so if anybody missed it and can go back and view it, I would advocate that for you. So without further ado, I would be happy to turn it over now to the rest of the conference.
Thank you so much for taking the time to speak with us this morning about those very important issues. We are going to be moving on to the next, or actually the first sort of forum discussion topic, which is the issue surrounding administration and systems of care.
Thank you, Patrick. My name is Nasu Malis. I work at the University of Michigan. I'm the director of our Pediatric Consultation Liaison Psychiatry Service.
Hi, everyone. My name is Matt Perkins. I'm the medical director for Child and Family Services at the New York State Office of Mental Health, or OMH. I'd like to give a big thanks to AACAP for pulling this virtual forum together. It's definitely a pleasure to be joining you on your computer or your tablet or phone, wherever you are today on a Saturday, and share a little bit about what we've been doing in New York State. So New York is a state agency which both licenses and operates hospital. It has a dual role. There are actually 22 psychiatric centers or state hospitals across the state. We call them PCs. There are 10 of them that actually have child and adolescent inpatient services. There are 4 dedicated child psych centers, and there are actually almost 330 beds across the state. And it's unique a little bit in terms of state hospitals in that we take direct admissions from ERs in some of our settings. And in other settings, we're more like a traditional state hospital who might take a child who's had a few acute admissions at a local provider and then needs a little bit longer stay, and we'll take those folks as well. We have a mix of payers across the system. We use fee-for-service Medicaid, and we also work with commercial providers. And in general, because we're a state agency, we do a lot of planning. That's one thing we're pretty good at. And so our first contingency when we were looking at this at the end of February and early March was really to say, what's going to happen if the medical system is overwhelmed? If the medical hospital beds are needed for the psych beds that are affiliated with those medical hospitals, where are we going to be able to step in? Those psych beds will go away. So we really felt like we would serve to be a release valve almost. And when the surge of patients came to treat COVID, we wanted to prepare ourselves to be ready to serve children who may need inpatient care. So it's one of our safety net responsibilities. The other contingency we had to deal with is what was going to happen with staffing. We certainly needed to prepare for staff being out due to COVID. And so that was one of the big pieces of planning we looked at. And then the other thing we were really concerned about is for all New Yorkers, how would New Yorkers access service? So not just only on the inpatient side, but also related to on the inpatient setting, how would we make inpatient services work if we have a lot of staff out or there are other challenges, et cetera. So we have one of these really cool things called the Continuation of Operations Plan, and we developed 3 scenarios. The current scenario was based on back in March when we had only 2 cases in New York State that were reported. It wasn't prevalent statewide. Local hospitals were not overwhelmed. And if you recall that long ago, it feels like years ago to some of us, right? We were focused on, had somebody traveled to a level 2 or a level 3 country? And that's what we were primarily looking at. We were focusing on hand hygiene, but we planned for scenarios when it might go a little bit more widespread. We've started looking at what do we need to do for PPE, N95 fitting, how do we don and doff? We are on our own as a hospital system. We don't have an affiliated medical hospital who's our partner to kind of give us guidance and support around PPE or around infection control guidance. So we had to do a lot of that on our own. We had to do well, and I don't want to say on our own because honestly, we've really had a phenomenal partnership with the state government. The governor's office has been unbelievably cooperative and has really pushed to get us the PPE we need. All the guidance and programmatic instructions that we've put out has been rapidly approved by the governor's office, really folks working 24/7 across the board to get a lot of this stuff done. But we had to create it and generate it and then get it approved. We definitely had scenarios in looking at how in this continuation of operations, how do we do screening, both for admissions, can we take patients that have COVID-like illness or who are potentially COVID positive? How are we going to set up isolation units? How are we going to do screening of our staff? What about visitation? All of this came into play in terms of looking at that. And then our big work was really, what can we do for staffing? We looked to see if we have volunteers who work in our outpatient sites. Maybe they would be able to volunteer to come and work inpatient. How can we limit the number of staff treating patients by reducing density or having variations in the staffing patterns on our inpatient settings, et cetera. And from all of this preparation and planning, we realized there was a lot of guidance, there was a lot of information that we had to start to disseminate. So this, for us, was pretty unique because we have a relationship with the governor's office, so we had to partner very closely with them. And I just want to echo again how cooperative and how wonderful the governor's office has been working with our commissioner and our exec deputy to make things happen and get us the resources we need. Then we had coordination across the 22 hospitals we support, including the 10 with kids services. We started having regular huddles. Those started to be daily. Then they went to, believe it or not, 7 days a week. Then they went to actually twice a day for 7 days a week for a period of time. We would meet as a central office team to discuss what the instructions and guidance and hotspots were. And then we'd have a daily huddle with all the hospitals with their leadership to give support and guidance. And then also we would pretty closely follow up at the end of the day with the end of the day meeting to discuss what we need to do, what needs to be done, and then really work overnight to get things ready for the next day. One of the things we found needed to be that was really important was to make sure that we got back to people when they had questions. So we established a virtual email hotline where folks could have one email address. They could ask any question and we'd work with our teams to get answers back to them. We also had a physician hotline. I cover Fridays. So if there's any questions across the state, there's a 24/7 doctor on call. You can call to talk and ask your questions. And we partner really closely with our Director of Health Services and our infection control leads if we have specific questions or need to get help out with that. And then one of the things we ended up doing, because as you can imagine, there was a lot of guidance and instruction, developed a hub, which is on our SharePoint that all OMH employees can take a look at, that really organizes and puts all the guidance together so folks could refer to that hub as updates occurred or as instructions came out. We put everything relevant on that hub. It took a little while to get that up, but that's been really, really helpful and has contributed, I think, quite a bit to staff morale. So the other thing we really had to do was, sorry about the slides there, is really work on tracking. So we not only had to track infection related to staff and patients, we had to track staff who were out. We had to track all these, the PPE, calculate the churn rate of PPE to make assessments of what PPE we needed, et cetera. So that tracking piece was really, really critical. So that, to be honest, was this whole process of coordination and communication, disseminating data and getting that out there. That was really, really important to try to get that right. Everyone has been, working on this. There's levels of stress. Some of the staff, frontline staff, rightly so, are scared. People are getting on edge. But we really approached this to say we need to do this to support frontline staff. It was very mission driven. We did it with a lot of repetition and consistency. We did it with kindness and support and validated staff. If people asked one question over and over again, that was fine. We'd walk through it with them. It didn't matter how many times they needed to ask a question, and we would work with them until we kind of got to a conclusion or an outcome that was advisable. We tried to time a lot of the dissemination that was going out so that we would put it out via an email with a PDF attached so it could go on the hub, but then we'd also on our huddle that morning talk about what that guidance was, what are the salient points, what do you need to be tracking, what to be aware of, and keep that as a way actually to support and help support morale. I think, we at least at one of our hospitals, we really got a nice bit of feedback from a staff member who said, we really appreciate this communication and the contact and the effort that leadership teams have made at all the hospitals. And the bottom line was that at least this one staffer who provided this feedback was that, I feel safe here in doing this. So that was a really important part of getting the communication and guidance right. This, just real quick, is to show you a summary as of April 14th, the guidance that we had pushed out. So it's quite a bit. There are lots of updates. It's a lot of work, and so to keep track of it is a big challenge. And from a regulatory point of view, how can we keep access going for the folks we serve throughout New York State? Is we really needed to jump in on a lot of regulatory relief, in particular around telemental health. There was a simple attestation you could do now, and you do the attestation, you say you're going to do your best to be as HIPAA compliant as you can, you have the technology right, and you jump in and you just do it. We added telephone to two-way video conferencing, so you could actually do visits via telephone and get paid for that. Of course, the DEA relaxed Ryan Haight a bit, so you could prescribe controlled substances, and in particular for stimulants, without this initial physical examination to keep new clients coming in. We also had relief from Health and Human Services Office of Civil Rights related to HIPAA. We had expansion to inpatient settings, and we also could do some of our involuntary work vis-a-vis tele. So that was a big help. We also relaxed documentation. We made it so you could do verbal consent. We said treatment planning, don't get together in a small room to do your treatment planning. Let's give you a break and let's do smart but simple treatment planning. Let's give you a break on the voluminous notes that we often make our staff do. We also kind of said with discharge in New York State, we expect people to be seen within 7 days post-discharge and have a medication follow-up appointment within 30 days. We gave a little latitude to get the folks out of the hospital, but we also made sure they had a supply of medications and they had follow-up available as needed. And then there are some other regulatory adjustments that were put in place. And we're going to come back and really talk a lot about the support, but I couldn't not mention the work that New York State has done with the emotional support helpline. This was a charge of the governor. He actually announced it at one of his press conferences on CNN. So when it first got up and running, we had a lot of callers from out of state. But really, this support line has helped thousands of New Yorkers address the additional stress and anxiety caused by the COVID-19 epidemic. And it now actually features an option to connect healthcare workers and first responders with specially trained volunteers who understand the demands of the epidemic placed on this group of individuals. And to date, we've partnered with about 11 other states to get a similar helpline set up. So we're going to save a lot of time for questions and answers, so I'm going to throw it over to Dr. Malice at this time.
Great, thank you, Matt. So let's see here. All right, these were some resources that Matt shared as well from the New York Office of Mental Health. So I'm just going to talk a little bit about staffing and the unique situations, unique settings that we have warrant kind of a delicate approach to how we think about staffing in the setting of a COVID pandemic. And so you want to start off with some guiding principles. These guiding principles are the foundation of the decisions you make, and they help communicate to your staff, which can be varied in terms of their skill set, their experience level, the type of care that they have to offer. And first and foremost, our primary principle was promoting safety. Safety for our patients, for our families, for our staff, and for everyone involved in care. We also wanted to be mindful of preserving PPE. We had a couple direct admissions to our inpatient child psychiatry unit that we had to navigate because they developed URI symptoms. And even though they may not have had COVID, they did require droplet isolation. And so we had to coordinate across our team and with that family to both provide support, but to also understand our system's limitations and facilitate care either through virtual bridging visits or facilitating care in the hospital, but being mindful of PPE use. And then obviously, we did not want to compromise the high quality of care that we pride ourselves in. Furthermore, we want to look at each unit's potential limitations. There's certain things that we can and can't do on each unique unit within the hospital. At the University of Michigan, we have an inpatient psychiatric unit embedded in our medical setting. We have a robust consultation service, and we have a psychiatric ER. And so we have to think about the space, the staffing, and the needs of each unit when we're thinking about how we want to model staffing. We also want to be mindful of equity, and this ties very closely to the nature of care that's provided by staff. So nursing provides more direct patient care, whereas a discipline like social work can do some care at a distance. But you obviously have to be mindful of the dynamics of what you're asking one discipline to do and the other discipline not to do, and be mindful of that in terms of distance-based care, virtual care, as well as direct patient care, and who needs to be present physically and who can do that care away from the unit. And this all leads to transparency, which I'll harp on quite a bit. It is really, really important to be transparent and open. There's a lot of uncertainty and changing dynamics, and that can create a lot of distress. And so we want to have regular touch points where we're being open about the data, open about the nature of the situation, and engaging all members of the care team in providing input and addressing their concerns. And be mindful that regardless of the crisis, that challenges and existing gaps in care can get amplified. So being mindful to address those proactively, and that also offers an opportunity to improve care, but that strengths also grow. And so people come together, teams develop, and things can really improve in a distressing environment. This is just an example of how we pursued staffing for our physician faculty. So the traditional model, we had 2 faculty covering 2 teams on our inpatient unit, and then we had 1 faculty member covering our consultation service. Due to changes in volume, and Dr. Karubia will be talking about this later, we actually collapsed our teams into 2 teams and removed one of the faculty members from our hospital unit. People will hear the term the Lombardi model. The Lombardi model is based on a staffing model from Lombardy, Italy, where there is frequent transitioning providers on a day-to-day or week-to-week basis to limit the amount of folks that are in-house providing care, providing access to direct care, but also rotating folks frequently enough to limit burnout. So what we did was, based on patient volumes, we collapsed the teams and we shifted our consult service to cover part of our psychiatric unit. And then we have a specialized unit that supports youth with significant ADL needs or aggression, developmental concerns. And then we created a rotating coverage schedule to ensure that if someone got ill in the hospital coverage model, that there would be ready access to somebody who could step in and provide that care. And we intentionally provided the first person to step in to be that other hospital faculty member, because they were familiar with the systems of care, knowing that they would likely be the first person to be called. And so it might be a little bit easier for them to be called upon if that was that need arose. And then we pulled from our ambulatory faculty if we needed to. And luckily, we haven't had to use this Jeopardy model frequently, but you want to be thinking ahead about the nature of your unit, the people that you have working there, and how you can strategically balance both the need for that supervision and care, but also preserving people so they don't get physically and emotionally burned out by being in the hospital for too prolonged of a period. We also want to be mindful of how mental health care delivery across systems can impact the children's hospital. All of our services are embedded within our inpatient children's hospital, which was also being utilized to manage adult and child COVID cases. One of the principles we followed early on was that we needed strong mental health support to enhance clinical workflow, both medical and psychiatric, because if patients had psychiatric needs and didn't have regular access to mental health services, that would not only be a counter to our guiding principle of providing high quality care, but would limit the ability of transitioning patients to where they need to be and receiving care in a timely manner. We had to think about physical space, and we'll talk about this a little bit later, but how physical space and congregating in physical space had to be thought about, and what infection control we needed to consider. Communication, making sure that that was crisp, timely, was provided during times that people could actually engage, and that we had the full breadth of stakeholders involved in that communication, and being mindful of communication across systems. So, the Department of Pediatrics being able to talk to the Department of Psychiatry, being able to talk to hospital administrators. There are all kinds of pockets of communication that need to be addressed. Creating those communications streams so that they're seamless and allow for quick crisis management, and then providing opportunities for regular engagement so that people are able to proactively think about issues on different areas in the hospital. And then we're now in a point at the University of Michigan, I think in a lot of places in the country, where we're starting to also think about the future implications of this. And there are some potential challenges that we'll all work through and we will get through. Fiscal challenges around staffing and potential hiring freezes, professional development that may not involve as much support fiscally due to fiscal constraints, strategic growth and expansion because of the fiscal environment, but also an opportunity for further innovation and delivery of virtual care, which can really enhance the way we deliver care going forward.
All right, thanks so much for those excellent presentations. We do have a couple of questions for the panelists. We have probably about 10 minutes to be able to address some of those. So we might as well get started. So the first question that we received came in during the presentation. It's, how are you managing COVID positive patients that require psychiatric care, but that would otherwise be quarantined at home. So patients who are relatively asymptomatic, who don't need to be in the hospital for necessarily medical reasons, but who have the virus and who need to be there for psychiatric purposes.
So I guess I'll just jump in and try to take a shot at that. If they meet inpatient level criteria, we've had COVID positive patients in our system. We have isolation units set up, staff wear full PPE. And so we really do that based on the level of necessity there. In terms of folks who are at home, that's where telemental health has come in, and you're gonna hear a lot about that, but that's been a real boon. I mean, you're gonna hear great stuff about telemental health. I did telemental health back at Columbia, starting in 2007, we developed a program, but people love it. Kids who haven't been able to get out to see somebody before are going out there and enjoying it. They're chatting and asking questions when they need privacy. We're hearing tens and tens and tens of great positive things about telemental health.
Yeah, I would agree with what Matt said. We're finding the levels of patient and family satisfaction with telemental health to be highly valuable. We hope to leverage using virtual care to provide bridging visits during critical transition periods, such as transitioning from the inpatient setting to the outpatient setting. And luckily, we have not had any young people in our hospital with COVID, and we've really tried to, as a system, focus on having COVID positive patients move into our medical setting with psychiatric consultation. But we've kind of prepared protocols and processes if we do have a COVID positive patient come to the unit. And we also have a negative pressure room, which I wasn't aware of initially, that could manage some of that capacity. But we've also had folks who are on droplet precautions for a variety of reasons, and have been able to manage that with effective communication.
Thank you. Another question came in. How are you managing patients with clozapine prescriptions in regards to lab work and follow-ups and the sort of face-to-face or physical requirements of that?
I can take that a little bit. We've covered that a bit more. We do that a bit more in adults in our system, but the clozapine REMS have relaxed some of the requirements in terms of once you're already on a regular schedule, you've been on clozapine for a period of time in terms of the schedule of the required blood draws. We also have a clozapine consultation team that's available, so we can kind of follow up, and if there are specific questions about that, we can ask that further. Where necessary, blood draws have been required. We've endeavored to make sure those happen and get them done. We have to balance safety with all these other factors, but we've been able to, for the most part, continue folks on clozapine.
There were a number of questions that came in that followed sort of a similar pathway regarding patients who were COVID positive, who required seclusion or restraint or weren't able to tolerate the typical interventions, particularly those kids with ASD or some sort of degree of intellectual disability for whom the typical sort of collaborative problem solving wasn't really an option in the same way.
Do you want to take that one and then I'll jump in, or?
Well, so we unfortunately, I can't speak as much to that because we haven't had a COVID positive patient on our unit to this point. But I think we have some processes in terms of rapid engagement of appropriate PPE. All of our nurses and staff are trained to manage care needs in the setting of COVID. I think it would, for us, at least in our system, the way it's set up, we would really be thinking critically about whether or not that patient should be managed on a medical setting or a psychiatric setting, depending on the level of respiratory illness and the risk of spread. But I think we would provide care within that context as we normally would, just being very mindful of the infection control risk and the environmental needs of that patient. But Matt, you may have some additional thoughts.
Yeah, I mean, I definitely think you focus more on the prevention side of that, right? We want to do everything we can to avoid an unnecessary restraint, emergency only for the most part. I think one of the unique things we found in doing this is we were trying to bring staff on board because we had a lot of staff out, and part of the staff training is how do you do effective and appropriate restraints, right? So that normally is something you do with each other. So we actually were able to do some via video. We actually were able to get some infection cooperative like mannequins to practice those moves on to help people. So we did have some staff we had to onboard who didn't know how to do the restraint. If the restraint happened in that setting, if you're already going to be working with somebody with COVID, our staff is already with full protective gear related to that specifically. I think the other thing I might just mention in terms of restraint is we did provide, at least in New York State, a little bit of regulatory relief. In New York State, believe it or not, the physician is the only one who can order it and has to be the person who responds. And we actually have to respond within 30 minutes, not within an hour, like the Joint Commission. So that was relieved a little bit. So nurse practitioners and others, nurse practitioners and PAs could not only order, but do the examination post the restraint. The other thing we had to do, which we gave guidance broadly to all hospitals, is isolation is not seclusion. There's a big distinction there. So you can have a patient. And so we largely were able to get around that in our adult hospitals, where we were able to have an isolation unit. So you could have an individual or a couple folks on that unit per se. So you wouldn't have them isolated in their room. For the most part, it was all about communication and education, both with the families and the patients. For the most part, even now with our governor's order for everyone needs to wear masks, encouraging kids to wear masks when they're not in their rooms, for the most part, we have pretty good cooperation. People understand it's really about being transparent, as Nasu was mentioning, and also kind of framing it and helping everyone understand the situation. So we haven't been able yet to look at quite at all of our uptake in terms of restraint across our system, but we anecdotally don't know of a significant uptick at all in restraint.
Okay. We probably only have time for about one more question. So one that came in particularly for satellite hospitals or private hospitals that don't necessarily have the same level of medical treatment is, what are the standards for testing, both in your institution and in transferring patients to other hospitals? Are you finding that hospitals are requiring testing or screening for your own units? Do you sort of proactively test patients who are admitted to the units? What are the protocols, and what do you think would be guidance around that?
So, this question will be partly addressed in the next section. I think Dr. Karoubi is going to discuss screening and testing. In terms of transferring from our facility to other standalone facilities that may not have access to the medical services embedded within, the psychiatric services, we have gotten some pushback from facilities wanting COVID testing and more extensive testing. But really, our health system has taken the stance that if clinically it's not relevant to test that individual, that we want to facilitate care in the best way possible. Obviously, if there's clinical rationale or issues that need to be addressed, we work with other facilities to do that in the best way possible. But we have not carte blanche kind of screened everybody that we're transferring. And if need be, then some conversations need to be had at a higher level to discuss what will help facilitate care in a timely manner.
Yeah, for us, as we're accepting patients, we are screening everyone. We're looking at symptoms. We're looking at fever of 100.4 over the last 72 hours. We want that information. If there has been testing available, we are effectively a safety safety net hospital system, and so we decided that if there are folks who either have COVID-like illness or have exposure, et cetera, that we would take those as a case by case. That's largely what the physician hotline is for, to discuss those individual cases. And then we have a whole set of protocol if we are accepting somebody in that scenario. Again, they can't have significant symptoms, otherwise they need medical support. Then how do we manage and keep them safe moving into our hospital system? What preparation, what location, how long of a period of time would we have them more on a quarantine type of setting? One of the challenges early on we were getting is if we had, and across all our settings, is if we had somebody who got a sore throat or had a fever, we'd send them to the ER and they'd just say, oh, assume COVID, and wouldn't test because there's limited. So we'd have a lot of people coming back, we wouldn't really have an answer. So our Department of Health was really good in developing discontinuation guidance that is both test-based and non-test based, related to how to discontinue isolation. So that's both on the New York State Department of Health website, as well as if you Google New York State OMH and guidance, all our guidance for other hospitals is out there as well. And so we've pretty much adopted that guidance in terms of discontinuation of isolation.
Well, those are great resources. Thank you for bringing those up and providing them. Unfortunately, though, we have a ton of questions and not a ton of time. So thank you both, Dr. Malice and Dr. Perkins, for the presentation and for taking the time to answer the questions. At this point, we have some left over, and we do have some time at the end of the presentation for more questions. So hopefully we'll be able to get around to some of those as well. But in the meantime, we'd love to move on to our topic of clinical service delivery.
Hello, I'm Bo Carubia. I'm joining you all from the University of Colorado School of Medicine, the Department of Psychiatry, and I currently function as the medical director of the consultation division within the Pediatric Mental Health Institute at Children's Hospital, Colorado.
Hi, and I'm Nasu Malice again from the University of Michigan, serving as Pediatric Consultation Liaison Psychiatry Director. So, want to talk a little bit about the environment that we're caring for patients in within the hospital setting. The picture I have here is what our inpatient psychiatry unit, our hospital embedded in the medical setting, look like. And as you can see, there's the chairs are not set up 6 feet apart, and there's lots of different spaces where you could see potential infection risk. And so a lot of thought had to be put into thinking about the environment and the space and how we provide care. And included in that is managing infection risk within care. And so initially, before guidance was provided, we were providing universal precautions, and then transitioned fairly quickly to having all of our staff and providers wearing face masks, and then being able to transition as much of care to virtual care as possible. We limited family visitation to one caregiver, and that caregiver was constant throughout the stay. And so you can imagine that by limiting family visitation, that has some constraints on the clinical delivery that you're going to offer, as well as can generate some anxiety from the patient being able to not see as much family during their stay. And this occurred both in the psychiatric inpatient setting, but also in our medical settings where we provide consultation. We had to think about our shared spaces. We have a cafeteria, we have an art room, we have several group therapy rooms, and had to physically space seating and other areas to be in compliance with social distancing guidance, as well as think about transitioning as much of that group activity to either a staggered schedule or transitioning folks to being in less consolidated groups, or even transitioning some of that care to virtual care when it was feasible. We tried to limit direct clinical care to only those folks that really required to provide face-to-face care, and tried to gradually transition as much of that care to virtual care when feasible, and tried to really have our trainees, our other staff, transition to off-site locations for documentation and other care needs, and really tried to limit how much time people were spending in the hospital, and limited it to a specific group of folks that would be needed to stay on just for any other kind of emergent care needs. And then all interdisciplinary team care went virtual, including our morning huddles and our daily team meetings on the inpatient unit, any meetings that were done on consultation services, as well as in our emergency room, and really tried to transition any intakes, conferences with family, care conferences with community providers to the virtual realm. And so this was constantly a balance between infection control, so being mindful of universal precautions, social distancing, having ready access to PPE if needed, or preserving PPE. So on our consultation service, we tried as much as possible, even with patients that were not under any respiratory precautions, to limit traffic in the hospital. We did not do consultations that required use of PPE in person when we could, and would try to do those virtually as a way to preserve PPE. But then, really trying to manage that with maintaining quality and engagement. And part of psychiatric care is socializing and engaging with family and engaging with peers. And so we try to be mindful of that and the interpersonal dynamics of that, as well as the need to make diagnostic assessments that would require some direct patient contact or interaction, but being mindful of that infection risk. And then obviously there are certain populations of youth with severe or profound intellectual disability, other social developmental delays, some of our youth with autism, some of our youth that had psychosis or other aggressive behaviors. There would need to be some level of direct engagement for diagnostic and treatment purposes, but we wanted to be mindful of that infection risk as well. Team meetings were held virtually, and we really tried to remove all non-essential meetings so that we could focus very clearly and directly on the tasks at hand. This required a tremendous amount of coordination because our teams are large, and sometimes we neglect or forget that the people that are with us in the hospital are not always all the people that we need to have included. So making sure the right people across disciplines, training directors, folks on the research team, folks on in other departments or in administrative roles are involved proactively in this process. You want to make sure you address technical difficulties early. So, trying to pilot the use of different platforms, practicing these activities with a small group of folks so that the technology is seamless. On our consultation service, we had a few iPads that we started practicing the use of different platforms to support patients and families in getting timely virtual visits. A lot of times, though, we used the family's native device to be able to do that. And then again, being as inclusive as possible. This is a time where things are happening rapidly and each day feels like a week. And there's a million emails and a million communications, and it's very, very easy to forget to contact somebody or let somebody be aware. And so as much as you can, trying to make the fellows aware of what's going on, trying to make sure your program director, your fellowship director, everybody who might have a say or might need to know, making them aware in some fashion. And then thinking about our care logistics across kind of broader domains. So, thinking about really trying to maintain consistency. One thing we, I think, struggled about early on is that lack of consistency, so the constant changing. So that's going to happen, but being mindful of telling people that early on and that you will update them as soon as you hear things, that you're going to be transparent, that you're going to have an opportunity for regular proactive debriefings and not reactive communications. And the message should be very clear. Try not to have a lot of ambiguity, although ambiguity is the nature of what we're dealing with. There's a lot of uncertainty, but try to be clear about what you can. And if there's things that you can't be clear about, just be transparent about that. Make sure data is available, because I think a lot of people are craving data right now, and always go back to those guiding principles. Try to anticipate needs, and that really involves engaging other leaders across systems to make sure you understand what all the potential needs are. Make sure you're talking to your nursing lead, your social work lead, the leads in different groups, and continually reflect on whether or not things are going well and where you can make improvements.
Thank you so much, Dr. Malice. So to continue on talking about impacts to clinical services delivery, since the initiation of this pandemic really early mid-March, we started noticing trends in many of the pediatric children's hospitals and academic centers. And as mentioned before, there's many listservs that we all live on and share information with on a daily basis. And what we really started to notice that many of the children's psych emergency room systems and consult systems we're seeing drastic decreases in census and volumes. I tried to give the best range that I could, encompassing everyone who was communicating, but anywhere from 30 to 80% decrease in volumes across these settings, which is a very, very large impact for this time of year. And some interesting correlations that we also found with that was some of those hospital centers were being asked to become COVID units for overflow or surge, especially for adult populations. Some of the pediatric hospitals were almost 80 to 90% adult patients because of bed needs and clinical care. So that tended to show if the hospital system was being more for surge capacity for adult care, they tended to be on that higher side of the decrease of census, which obviously makes sense. But then there were also some units and some hospital systems that were relatively unimpacted by the adult patient need. So some centers actually saw some reported increased consult volumes, and we were actually one of those centers. So at Children's Hospital in Colorado, about the past 2 or 3 weeks, we had seen maybe a 2 to 3 times increase of volume in ingestions. And not only were we seeing more ingestions, the acuity of the ingestions were much higher. We had a couple patients coming in on intubation and ECMO, which we see once every blue moon, and we were seeing multiple within weeks. So the acuity of the ingestions were going up. Also in other centers, somatic complaints, a lot of anxiety and kind of worries. So, you know, some of the questions that were posed, well, why? Why are we seeing this? Well, one obvious answer is if the hospital is being used for adult services, we're going to see a dramatic decrease in children's census. But there's also a fear. You know, their parents are more frightened to bring their kids to their PCP offices, to the emergency room. We're really, truly seeing a decreased utilization of care. Some of that has to do with messaging to the community. In some communities, there's been a lack of messaging or even some negative messaging that's out on social media and things like that. And in other communities, there's been a lot of positive, proactive messaging. And that tends, again, to correlate with potentially worsening that fear, as kind of discussed above. I already kind of touched on the adult and kind of pediatric use of the beds, but across settings, we all know, you know, when we transition to summertime, it's common that our psych emergency room volumes go down. That's actually kind of a normal peak across, or a normal trough across the nation. But we kind of saw that immediate trough. Schools were out. They were not obviously a referral source for emergency rooms. Parents are now home. A lot of parents are working from home and with their children. So there are some correlated ideas as to the why. But still, a lot will be found out over these issues in the months to come. If these are our new trends, are we in an early summer, quote unquote, in terms of our volumes, or will we see a peak? Will we see an increase of acuity? We will be finding that out. Another important piece. Another important piece to consider is screening. So I know Dr. Perkins and Dr. Mallis kind of touched on this a little bit before, and this was my best attempt to give a visual representation of what hospital systems are thinking about in terms of screening and testing for COVID, and how are these impacting practice. So when I think about this, really screening and testing are two separate entities. So early on, screening was really based on talking to symptomatic patients with positive COVID contact or a positive travel history. That then transitioned into screening symptomatic patients and or staff, family members, regardless of their context or their travel history. And then on the further side of the spectrum, once you get to the place of screening asymptomatic patients and or staff and family members, how does that impact practice and care? And another important qualifier is symptomatic patient. That is defined very differently in some systems. Some are solely focusing on fever. Others are focusing on cough, shortness of breath, aches. What criteria is the hospital system or healthcare system using as that screen? And again, just speaking from my own experience, I saw that we initially started screening symptomatic patients with those histories of contacts or travel. But as of now, I get screened every single day when I come into the hospital to work. Same with any patient, same with any visitor. We have to answer our lists of, do we have any active symptoms? If we do, we're sent home. If not, we're cleared to work and we're screened negative for that day. So in the same vein of screening, testing is also important. A system could be screening at the highest level, but have very few or limited testing capacity. That's going to have a large impact on practice. Initially, testing was looking at hospitalized patients, acutely ill patients, those that were in the ICU. Some centers are testing symptomatic patients and or staff. So again, on their screen, did they screen positive? And then if so, are you testing them? What kind of supplies of testing or resources were available? And then again, on the farthest side of the spectrum, testing asymptomatic patients and or staff. So again, I'll speak from my experience at Children's. We were fortunate to have our lab develop an internal test. So again, we started off more on the limited and potentially robust side. But at this point in time, any pediatric patient coming into the emergency room, whether they have symptoms or not, is tested if they are to be admitted. The turnaround time on that test is down to 3 to 4 hours. So we have created a system where we can test patients to the degree of a really universal and high level, and that is potentially impacting clinical practice. That's potentially opening up doors of how quickly can we bring back ambulatory practices or surgical practices. And again, when we think about screening and testing within system settings, it's really important to think about in your system, where are you? And in terms of those tests, how much are you going to be able to impact care and kind of direct future care? So along those same lines, when we are thinking about virtual tele and mental health, as Dr. Mollis and Dr. Perkins kind of shared earlier, there have been tons of delivery platforms used. Again, just speaking with colleagues across the nation, the number of different services out there to use is quite numerous, and I'm sure will be growing in the months to come. There are many systems that have integrated video platforms within their electronic medical record. Some very common ones that have been used are video, Zoom, Skype, FaceTime, Microsoft Teams. There are various advantages and disadvantages of using these systems, and there's far too many for me to even try to discuss within the setting of this platform. But one of the key issues when thinking about which one you're going to use in your clinical system is privacy issues, HIPAA issues. You know, some of those regulatory issues have been relaxed, as I'll comment on in a couple slides, but you know, part of my common language that has become day-to-day is, are you accessing these services within or outside of your hospital network? Are you using the VPN? These are all things that I never really thought I could kind of think about in the past, but now kind of have part of my day-to-day. Scheduling and timing. So imagine we're in a clinical hospital setting, as I was here, and all of a sudden every clinical department is using tele at the same time, and we all work at the same time, 8 to 5. So incredible bandwidth issues during peak hours. So this really begged for early morning sessions, evening sessions, weekend sessions. We had to kind of spread out all of that information, all of the time when we could provide this care. And with that came administrative burdens and training burdens. We had to create templates for clinics. There's a lot of technology and IT troubleshooting. Training, we had to train faculty and staff. We had to train families. How do you access these services at home? Can you connect to these services at home? And then live support. When things go wrong, you need folks there to be able to be helped. Documentation. We have to document the consent for telehealth services. We have to document location of the patient and the provider. Traditionally, in the clinical setting, the provider was in a clinical setting and the patient was in a clinical setting, and we were just connecting. Now it's more home and home. So those things need to be documented. We have to document the type of technology we're using, audio, audio-visual, and then again, huge explosion in templates and smart text use. So lastly, just wanted to kind of wrap up talking about billing. Billing is always on our mind. It's something that people constantly talk about in our background besides our clinical responsibilities. But again, previously, if I was providing telehealth, I would be in the hospital providing that. Well, now I'm providing it from home. So the facility fees are lost. And what kind of financial ramification will that have? As probably in many of your states, emergency waivers have been passed. Previously, telehealth was only allowed through audiovisual, and now we can use a telephone call and bill for it. The location of the provider and the clinician, very important. Again, are you at home? Are you in a clinical site? Is your patient in the same state you're in, or are they a different state? These are all things that we need to think about in the billing world. Professional fee charges, not forgetting to put in the modifier, my new favorite modifier. And then again, state by state, there's different telemental health rules, and many of the states have relaxed those for 30, 60, 90 days. And same with HIPAA rules and the use of those different platforms. How long will that last? Will those continue future forward? And the last points to kind of think about is, how are these changes going to impact our future hospital-based mental health care? It's hard to imagine that portions of care will return to fully in person. Parents and patients, the positive feedback we've gotten, it's far too convenient to deliver their care to their home on the weekends. We don't have to do school excuses. We don't have to get work time off. Some of these things are going to probably stick around in a very large way. We've really opened doors to the platform of virtual and care delivery, virtual outpatient, intensive outpatient, partial hospitalization programs. These are all things that we can think about. And so I guess my last point that I wanted to wrap up with was, what one person sees as a potential, another person is probably going to see as a risk. And so I think it's going to be very important that we balance these opportunities as we move future forward in virtual versus in-person care, and how those two mesh together.
You're on mute, Pat.
Sorry, just talking to myself. What I was saying is we have a bunch of questions. Care delivery seems to be something that a lot of people are struggling with. So I'm going to start with sort of general themes that have come through. So one theme is, how are you supporting the sort of differential level in how care providers are able to interact with patients, so that it doesn't seem like a multi-tiered system? So for example, whereas many of the physicians, especially the attendings, are able to work remotely, some of the frontline staff, the nurses, the SAs, even the residents and fellows have to have much more face-to-face interaction and may feel that they're more at risk. So how are you balancing that difference, and how are you sort of maintaining morale throughout this process?
Yeah, so I can start off, and that's a huge issue. And the other kind of layer I would add to that is, we're talking about this retrospectively. This was happening and changing actively for the past 5 to 6 weeks. And so, you might say one thing on a given day, and then policy changes across the health system. And, to give you an example, the use of N95 masks was a big issue across the country, and who should be using them for what types of patients, and how should they be distributed and such. And so what's been helpful, I think, is trying to anticipate some of this, being really open and saying, look, we're all going through this together. Things are changing very rapidly. I will let you know as soon as anything changes. Our chair was really thoughtful in sharing a lot of data with us and sharing what he was hearing, so that it could keep us kind of grounded as to what the general message was throughout the health system. Our health system was fantastic in sending out daily emails, holding town halls. And so that's why I shared those guiding principles, because when you go back to it, you go to those guiding principles, you follow those, you follow the health system practices, And then you really need to engage everybody and develop consensus and then go from there. So we transitioned from being a very staffing heavy model to then selectively having folks work outside the setting based on what their care delivery was to the patient and based on how the shifting guidelines were within our health system. And I think as long as you're transparent and very engaged with your team and know them, there are certain people that may struggle more. And so taking them aside and walking them through, talking to them, listening to them, being kind of reasonable about how you can support them, but then being mindful of the dynamics in the larger group. Generally, if you take that approach, things will go well.
I would echo exactly what Dr. Mollis said. We actually had this exact conversation when we were discussing this topic. And I would just echo, do it very delicately and do it very thoughtfully. As he said, every day something seemed to change. As an example I can give you, we were setting up virtual use for providers to go into a room. Our technology was having issues, so we needed somebody to hold the iPad. And one of the arguments we made was, well, we wanted to remove a person from the unit to decrease overall exposure risk. But then in the same vein, because of a technical issue, we were saying we might need an additional staff member to hold an iPad. So when we were making those kind of conversations, it does bring out some interesting, well, how does it make sense to remove a provider and add in a staff member? And we decided it didn't. So it was a very thoughtful discussion going forward. But as Nasu said, I think transparency was the key guiding factor. As much as we could pull back from the emotions and talk about what was the true north, what were the objectives, and as long as we could all get on that same page, I think those discussions went better.
A somewhat related question came through about coordinating care among multiple providers who are all working with the same patient, that you can't just sort of stop by the rounds room or run into someone on the floor in the same way. So if someone's being seen by social work, by child life, by multiple different teams, how are you working out those sorts of either team meetings or care coordination?
Yeah, I can take a quick stab at that. I think we moved our rounds to virtual rounds. So if a provider was seeing the patient, we would do our check-ins with each other virtually. We would do them frequently. They wouldn't be very long, but we appreciated not everybody was on site. People were in different places. Even when we had providers in the hospital, we were trying not to all sit in our tiny little team room. Typically on our consult team, we can have up to 10 people. If 10 people were in here sitting with me, there's no way a 6-foot rule. And so we quickly adapted to virtual clinical and team meetings as well. So really trying to bring in all of those entities as in real time as possible, like we would have on a normal day-to-day face-to-face, but using the technology to our advantage in that place.
Yeah, and I would echo that. So there's a few things that can help with that type of complicated care coordination. One is we developed a lot of consensus guidelines very rapidly around how we would provide care protocols on our unit. We talked about screening and testing. There were hospital-based guidelines, and then we kind of modified them slightly or kind of within the spirit of what was being addressed to kind of meet the needs of our specific units. So that was one thing that was very helpful, because when you have consensus, you don't get as much variance, and the variance causes a lot of distress. Why are you letting nurse X do this, not nurse Y? Mm-hmm. Why are you doing physician X do this? And even within the discipline, being mindful of how faculty changes can affect fellows and how fellow kind of leaves can affect, faculty. And, there's all these dynamics that are going on that I think we weren't as aware of, or maybe were not as palpable as now when people are just, going through a lot, dealing with a lot, and trying to understand and process everything. And then the other thing too is just checking in, a 5-minute phone call quickly to check in. Hey, I'm going to go see this consult. Let's coordinate with our psychologist, with child life. We're going to do an assessment in the ER, who's going to be the person who has to go in and do the kind of brief physical assessment? It's usually the attending, and that's one thing we kind of did pretty routinely, is the person in the most senior role tended to be the one who was the person who would do the direct care and really allow other folks to work virtually. And I think by modeling and by taking that leadership role, that can really set people at ease and reduce some of the angst about coordinating all this.
Great. So we have time for one more question, but it's a big one. So with the global changes that are happening in the world, what have you noticed in terms of changes in patient populations, presenting complaints, mania psychosis, suicide attempts with household items as opposed to other methods, in terms of the kids who are actually making their way to the hospital, who are actually rising to the level that they need to be seen and evaluated in that manner?
Yeah, and again, I can share a little bit, as we were one of the centers that saw a peak in some of our volume on the consult service. In our world, we were seeing many more ingestions, and some of the ingestions we were seeing were not your common household varieties. They were medications of people who were in the home. So again, you can think people are potentially cohorting. When they are staying at home. Sometimes we have grandparents and parents and other people kind of living amongst others at times. So we were actually seeing much more overdosing. And again, somatic complaints. The kiddos who were having a lot of anxiety and mood concerns with this, we really were starting to see higher levels of that in addition to other kind of CL services as well. Again, but that's just a small sampling. We're just one hospital. I think going forward, the concern is that those ingestions and the safety evaluations might stay steady. I thought it was just going to be a 1 or 2 week peak. It hasn't. It's been ongoing, a little bit higher than our normal volume. So hard to forecast for the future, but this evaluations and acuity is what we've really seen.
Yeah, and I would just add, I think each of us is kind of going through a unique experience because of the nature of how our systems are set up. So, our system is heavily embedded in the medical setting, and so the way we experience things may be different from a standalone hospital or a consult service that doesn't have a co-located adult hospital. Our children's hospital was utilized for COVID care, and so a lot of families, I think, may have been a little bit distressed. They verbalized that to us on the consult service, at least. And then, how the systems are kind of thinking about ramping up also has a significant impact on how space is utilized, how services are utilized, and so there's all these dynamics that are going on, and so you can see one area where you have a significant decrease in volume, another area where you have a significant increase. We have, I think, uniformly heard that folks with developmental delay, autism, folks with significant trauma or family psychosocial issues are utilizing hospital services at a higher proportion relative to pre-COVID times. Partly because systems of care in the community are a little bit limited, but partly because staying at home doesn't necessarily reduce some of the stressors that we would see in other populations. But other than that, it's really, I've seen it be vastly unique across different areas.
Well, thank you, Dr. Caravilla and Malice, for your time. At this time, we're going to move on to a topic of training and education.
Hey everyone, I'm Anik Jansa. I am an assistant training director in the CAP fellowship program at the Children's Hospital in Philadelphia, and I'm also director of our emergency psychiatric services. Does this work? Oh, there we go. Or not. I am not sure what's going on with our slides. So. Oh, all right. So in the training world, we are working to ensure that safety from this that we've all been dealing with doesn't necessarily lead to this. And I'm just going to assume everyone's laughing and having a good time at home because I can't hear any of you, and talking without feedback is difficult. The ACGME has implemented numerous changes in adjusting to the COVID period. But reminders for everyone, work hour requirements are unchanged. ACGME does tend to view work from home as same as work in a hospital. So just because someone's doing telework from home doesn't mean that they're still not on the clock and we're still not counting those as duty hours. Any redeployments, I know that there have been talk in numerous institutions about having your trainees volunteer in ICUs and medicine. I know that some of this has happened in some of the more heavily impacted areas. Changes of redeployments greater than 4 weeks need to be reported. Trainees need to be fully trained in treatment and infection control across all specialties. So if we are having trainees on consult services, on call, seeing patients who are COVID positive or even suspected COVID cases, we need to be ensured that we're protecting our trainees just as we would anybody else. Self-study visits are canceled at this time. Telemed supervision is something that we've all had to learn, rapidly adopt, and become good at. And this takes multiple facets. This is both doing weekly supervision over video with a trainee or by phone, which I think sometimes people have done, but also supervising their cases and popping in at the end of a case, much like you would staff a consult or staff an outpatient visit. And you can pop into the video visit and staff that way over video is also allowed by ACGME. And then the resident and faculty surveys that we all love are currently discontinued. Review meetings of programs are going to continue. ACGME says to expect some delays, but they are going to continue virtually for the time being. We've sort of been in constant communication with our fellows, and I see one piece of feedback from one of our fellows that really hit me and sort of was very rewarding was actually one of our fellows said, I never would imagine being so protected and looked out for by a program as they felt in how we are doing now. So that put a smile on my face and let us know that, we're at least trying to be responsive and there for our trainees. Some changes that we've made at CHOP in the COVID era, we've moved, and I think a lot of programs around the country have done similarly. All didactics are being done virtually, coordinating with speakers around how to make that happen. I already touched on virtual supervision. We're doing regular wellness checks with our trainees. And I think a text, an email, a quick phone call, spending a few extra minutes after you staff the cases, just be like, hey, how are you doing? How's your family? How are you holding up? How have things been in terms of your childcare? And, trying to make sure that you are if your trainee is not in a good place or if they're having struggles of their own, it's going to be hard for them to learn, especially in a different learning environment that they're not used to receiving learning in this environment, and we might not be used to providing education in this environment. And so just, a little time there goes a long way. And then one of the things that we did in our first week when a lot of the changes happened in terms of clinics being canceled as we're trying to figure out a new world order, we did a lot of rapid and training certification for fellows to be able to work via telemedicine. The reason I mentioned this here, I'll touch on this later, but July 1st is around the corner and we are going to have new trainees coming in and perhaps thinking about how to get some rapid training built into your orientation schedules for your new trainees coming on. Similarly, if you're having resident rotators, med student rotators, trying to get some of this information out to them early before their first day of rotation so they can have training and how to do tele visits can be very helpful and can sort of get you ahead, and so you're not spending days of someone's rotation trying to get them trainings and certification to be able to work with the rest of the staff. Reduction of in-house and transit time, canceling of clinics, lighter clinics, non-essential visits being canceled, has also allowed for greater focus in QI research and scholarly activities. We actually had some of the QI heads in our department send out regular emails to folks about, hey, here's existing QI projects, here are things that people could use help with. So it's given opportunities for trainees and other folks to get involved in QI projects that they might not have had time with before, or it's just, that research project that's always been percolating in the back of your head or the back of a trainee's head, but no one's really quite had the time for. Trying to use some of these changes in terms of clinics that haven't quite figured out telemedicine or haven't quite figured out how to fully utilize trainees, reallocating that time to scholarly activities is something that, I'm hopeful that as AACAP as a group, we will see a benefit down the line of maybe increased poster participation, increased presentations that we could have at future AACAP from our trainees having more time to focus on some of these things and being able to put out some wonderful work that they're capable of. In our outpatient trainee clinics, initially all non-urgent visits were canceled to reduce exposure and preserve PPE. We've actually had all of our fellows successfully transition their caseloads to telemedicine, and new patient visits are being done directly via tele with direct real-time supervision. That either means it's taken on a few different ways. We've had people either in the same room socially distanced, so they're both on the computer together. We've had people providing both the attending and the trainee are on the video visit together with the patient, or the attending is sort of popping in at the end in terms of a more traditional staffing model where you kind of come in to the end of the visit, or you pop on the video at the end of the visit to provide support and to staff the case. Fellows are also able to contact supervisors directly, either via call, text, and if there's unexpected issues such as safety concerns, and then those, even in the past where we've had our own patients might not be able to run and jump, and you might have to sort of juggle to be able to help a trainee. We've actually been able to have sort of attending support networks available for our trainees, so they're able to contact an attending and have them hop right on the video visit if there is a question of safety or concern for a patient. To be able to increase in some different ways our support and our ability to be there for our trainees when they're dealing with difficult cases or difficult moments. In a pediatric hospital, I know some of our other presenters have touched on this, but we've actually had our fellows working remotely, and trainees have been handling the pager remotely and managing issues from home. They are seeing new consults and follow-ups via tele, and they're staffing cases by having the attending join at the end of the video visit, if we would have come and entered the room or gone back to the room together with the trainee after they presented to us. We've also made a lot of changes to our call structure. So traditionally in the past, we would have our trainees come in and round on the weekend with an attending to both reduce exposure and reduce PPE usage. We've actually stopped having the trainees come in. An attending has to see a patient every 24 hours anyway. So the attendings are coming in and rounding on their own. We're asking our attendings to check in with the fellows post-rounding to discuss the cases. We're trying to create new opportunities for teaching when we've lost some of our old ones. So we're having these we're having our attendings talk with our trainees, run through the cases, go through the salient teaching points. Both help in terms of the fellows are still manning the pager, so if they get paged about the patient, they can speak properly about what's going on and what the updates are on the patient. We're also providing a sign out on the patient back to the fellow so they can be the front line to manage a case, as well as being able to teach about what's going on with the patient. We've actually switched all of our new emergency department consults over to telemedicine for trainees and for fellows. This has actually allowed our fellows to continue on with their call, especially their weeknight call, as they would have before, without sort of risking exposure into spaces that are higher risk for exposure, but continue to provide service to our patients and families. And we have been working with our trainees in terms of deferring non-urgent consults in weekend periods where we have some less capacity to do new consults via telemedicine currently, and those we're working to see them via tele during business hours when possible. Obviously, if there's a patient safety issue, clinical care comes first, and we are seeing those consults when appropriate. But if it is something that could potentially wait, 16, 18 hours to the next day, we are working with our trainees on how to do that. And so fellows are also no longer required to be in person on weeknights. The attendings have actually assumed that responsibility for our trainees, and that is something that we as a group decided to do. We felt that if something was really going sideways or haywire, then an attending would have to be there anyway, and we didn't want to put our trainees in unnecessary risk for exposure if we could have another option. Some of the inpatient experiences, some of the things we've done, we sort of worked to make sure there's adequate PPE and hand sanitizer are procured for trainees. The reduction of their rotation to actually having them only in person for 2 days to reduce exposure in highly trafficked areas where social distance is more difficult. And then that's actually created some new ways to use trainees in family meetings, presentations, obtaining collateral in the days that they're not in-house. So we're still working to provide an adequate and proper training experience for them, even if they're not coming in the building on that specific day. Some of the feedback we've received from our fellows, I found it reassuring that we were able to continue to provide effective patient care in spite of the challenges and things that comes with things rapidly evolving, and feeling that their own physical and mental well-being was being taken into consideration and prioritized. I was personally impressed and grateful for the prioritization of fellow safety at this time, and gaining the sense of part of a community during all this actually felt like an extra sense of support to them. Additionally, some of them said sort of balancing health and education was viewed as a priority amongst our trainees, which they said that was a privilege made possible to them by their attendings. The continued communication and transparency regarding the evolving protocols. I can't tell you how many follow-up emails I've sent to our trainees and be like, hey, that thing I sent you 3 days ago, 5 days ago, that doesn't apply anymore. Now here's the new world order. And fortunately, they've been able to roll with that and go with that. But trying to get that information out as readily available as we can, and then involving the fellows and actually crafting some of the telehealth protocols, having them involved in making the job aids, has been helpful for everybody because they're the users, and so they've been able to craft how we do things. And then regular reminding and resources for self-care has been really invaluable. So a couple tips to summarize. With high level of anxiety, excessive communication has actually been viewed by a plus, and the feedback we've gotten is that's been very helpful, both with your trainees as well as the service directors who are working with trainees. So if there's a new update, just because you emailed earlier in the day, an hour before, 2 hours before, a day before, it's okay to send another update and sort of summarize, hey, I know this is what I said in the last email, but here's the newer update. Sometimes some things are only good for as long as it comes out of my mouth, and then 5 minutes later, I'm giving you a new update on the new world order. Get creative. How you used to do it doesn't likely work right now, but there's also a lot of new opportunities for how to provide training, how to provide support, how to how to help in this time. And then it's a great time to reimagine the experiences your trainees have and find ways to focus on their strengths to provide strong educational experiences. So some considerations for the future: virtual graduation. Maybe start working on goodbye videos from staff. Gifts might need to be emailed or mailed to trainees and graduates. Or July 1st is 67 days away. I know it's a little crazy, but start thinking about team building exercises that can be done remotely, opportunities for rising chiefs to be involved in the creation of this, utilizing outgoing graduates to establish and update job aids for COVID, and reorganizing orientation schedules to maybe cluster the days that they need to come in versus the days that things can be done virtually to also help with that. And then AACAP, this is our schedule coming up, start planning for possible virtual interview seasons. It's all around the corner, and we're about 2 months away from ERIS opening up. And last but not least, I would be remiss without mentioning our training team. Dr. Jaragi on the left is our CAP program director, as seen on CNN this morning. Nikki Kim is our program coordinator. Dr. Sarah Arshad and Dr. Amy Kim in the middle and on the far right are our post-pediatric portal director and assistant directors. And then Dr. Kugandi and Dr. Home are also involved in our CAP fellowship. And this has all been a team effort to make this happen. And all the work I presented has really been a collaborative effort and hundreds of hours of work from these folks. So I want to acknowledge them. And that is it.
Hi, thanks so much. Again, we got a good number of questions. One that seemed particularly interesting to a number of people was, how are you handling trainees in sort of special circumstances? So the specific question that was asked multiple times includes pregnant trainees, but I would also expand that to trainees with asthma or who are otherwise at possibly elevated risk.
So trainees and attendings both, I think we've made a really strong collaborative effort in terms of our department has actually compiled a list of people that were able to apply if they felt that they fell into one of these buckets where they were at increased risk. And we've really, frankly, made it a priority institutionally to try to protect them and keep them out of the line of fire that involves trading calls, giving away calls, moonlighting opportunities. We've had even some of our attendings have given away their weekend calls, and we've had other attendings step up to the plate and take them from them. It's a team effort, but really working on how to find ways to utilize them appropriately, and that might be from a distance or remote setting, so they can continue to use their education and expertise, have training opportunities, but also not unnecessarily put them in risk when possible.
Right. Another question that came through was about trainee and resident anxiety, particularly around not only exposure, but redistribution, having to take on additional roles that they may not be used to or as familiar with. I'd say especially when you're not sort of there with your door open for them to come to. Have you seen trainees requesting additional services outside of the training program in terms of support or anything along those lines?
Yeah, so I think everybody's anxiety is higher right now, trainees, nurses, staff across the board. Continuing to push out your existing resources, whether employee assistance programs, really, we have some fabulous folks working on wellness within our department, and they have been amazing in terms of pushing out resources, using our AACAP listserv. There's been a lot of resources put out through AACAP. Those that are involved in training the ADPERT listservs as well have also been very helpful in terms of having these resources, whoever has them, people have just been sharing left and right, but really making sure that sending it out multiple times and be like, hey, just a reminder, here's some of the resources available, because they might not have had time to process it March 10th or March 15th, but now the sort of reality of the situation is dawning on them, and they might feel like they need a little extra help or support as their circumstances have changed. So continuing to push out those wellness resources, continuing to check in on folks, and then really making sure that if you feel like a trainee is at risk, working with their supervisor, working with their direct support, and saying like, hey, I'm a little concerned about, this person over here. Can you check in with them a little extra? Can you make sure they're okay? And if some extra help or support needs to be provided for that trainee, really, this is the time that we all need to go above and beyond in multiple aspects, and going above and beyond for our trainees is no different.
Well, thank you so much. Unfortunately, we're about out of time for questions. Need to keep the trains on the tracks, but we will have some time at the end for all of the fantastic questions that did come in about this really important topic. But at this time, we are going to move on to managing the stress response and psychological trauma for staff during this unusual time.
Hi, everyone. I'm Dr. Kyati Brambot, and I'm the Director for the Child and Adolescent Consultation Liaison Service at the Benny Children's Hospital in San Francisco, and an Associate Clinical Professor in the Department of Psychiatry at CSF. I'm really thankful for my co-speaker and all our panelists, and I'm gonna let Dr. Foyer introduce herself, and then we can start talking about this really important topic.
Yes, hi, thank you. My name is Vera Foyer, and I direct the Pediatric Emergency Psychiatry and Behavioral Health Urgent Care at Cohen's Children's Medical Center, which is part of Northval Health, which is in New York City, which has been the epicenter of this pandemic. And we're excited to talk to you guys about this topic, and I'll let Kyati start us off.
Thank you. I really want to express my gratitude to have this really village of colleagues and resources and supports as we're all navigating through this. And as I'm sitting hearing a lot about what everybody has to say, one of the thoughts that came to mind is, we were all trying to do this. It was a little bit like trying to build your boat while you're sailing in rough seas. And one of the things that was really important as we started thinking about putting together resources for stress response and psychological trauma is having a sense of, where we are, and getting a sense of where you start off with, and a true north, as you've heard some other people talk about, as to where we want to go, and that ideal of supporting as many people in effective, efficient, useful, long-term ways. And really one of the guiding principles in terms of helping us get to that point is making sure that whatever services we put in place, we're going to be with that long-term goal in mind. This is really a marathon, and the services need to continue beyond sort of the acute phase of COVID. And as we do that, really starting to think about, what are then the specific details of meeting these guiding principles of support in psychological trauma for COVID and beyond. And one of the things as we started looking at what our needs are is we were thinking about the Maslow's hierarchy of needs, with the very bottom being kind of our basic clothing, shelter, then emotional connectivity, a sense of belonging and agency and then meaning making. And as we started talking about this, we realized that, at least for our group and our local culture, where we wanted to put a lot of emphasis was on the physical and the emotional needs, because that's where a lot of us are really at right now. But this might look different based on where you are. You know, a department chair or deans might actually be looking at belonging and making sure what you heard before, that their communication to their various, groups is very compassionate, consistent, that they're, making sure that they're generating this sense of belonging. As we started talking about, how do we go about supporting this emotional need, we also wanted to make sure that we realize there's a whole range and a spectrum of these needs, and what resources can be put in place to address these needs. And on the one end of the spectrum is really universal support that everybody needs and accesses, and these are things that can be done asynchronously and in their own time. And these are things like apps, whether it's relaxation apps or helping you sleep, online websites and webinars, lots of other financial resources, grocery deliveries, how we connect with each other via all these online platforms. And then on the other hand, at the other end of it is the intensified support, where you're really looking at clinical level needs with therapy, medication management, and other programs that either departments of psychiatry or your institutions with partnerships might put into place. And what we really kind of found is what is really needed, that there were lots of resources in both of these areas and things were easily ramped up, and where we really wanted to shore things up was this middle bucket of supplemental support. And when I say supplemental support, what I'm talking about is sort of on the grounds, unit by unit, group by group, peer support, individual support. And as we started looking at how we were going to put in place these things, the first step was to make sure we had a list of all our stakeholders and all the people that we were going to partner with in order to do that. And this is just a short sampling of spiritual care services, palliative care, a lot of our community partners, in our CL service, Child Life and social work, and in our task force that was working on this, we had included facilities and security, and it was really meant to be as inclusive a group as possible. And once we put this group in place, we also wanted to make sure that we identified champions, because people were not waiting for us to sort of put together a vision and mission and structure. The lovely thing about champions is they get to work, and we know that a lot of these individual units and groups already had champions doing a lot of this work, and so we wanted to make sure that we identify, amplify, support, and help them organize. And so we started by identifying champions for these individual units, and then putting some best practices in place. The big themes that we identified as we started looking at these best practices were trauma, and the help and need for trauma-informed care, a sense of grief and loss. So much of our life, including this lovely forum, is two-dimensional at this point. A sense of guilt sometimes for not being as impacted as maybe some of our other colleagues were, or not being impacted in the same way, the guilt of feeling like we were privileged in many ways, and a sense of loss and moral injury. And we really tried to address all of these areas by putting specific programs into place to address all of these areas. And I'm gonna really hand it over to Dr. Hoyer to talk a little bit more in detail about all of these individual things.
Thank you so much, Chiari, for that nice introduction. And I'm just going to go into a little bit more detail with some examples from Chiari's institution, UCSF, and some examples at Northwell Health about each of these levels of support. So like she mentioned, really the basis of all of this is universal support. So universal support can look many, many different ways. It can be asynchronous, so giving access to employees to resources. At Northwell Health, everybody has even without COVID, we have a very large employee wellness group and initiative and department that helps employees stay well. And we all have access to the Virgin Pulse app, which has things like exercise, meditation, tips for diet, healthy recipes, you name it. It's sort of on there, and they sort of ramped that up and added additional resources on there for people to be able to use during this time. Employees also have access to an app called Joyable, which is a therapy app, which is free of charge, and you can have sort of online therapy sessions guided by this app. Another one is a Bottle Cap, which is an app that helps with curbing substance use. And currently, during the COVID pandemic, they also launched access to something called the Clinician Experience Project, which is webinars specifically to help providers deal with the COVID pandemic and to help them also help their patients deal with the impact of the pandemic. There's also some examples of synchronous universal support. People can, for example, tune in to brief 5-10 minute breathing, stretching, exercise, mindfulness exercises several times a day, every single day. We have a code for it. It's ITT is the name in this together, and people can, on their own time, tune in whenever they want. These are, again, very brief and are provided multiple times a day throughout the day. We also have had support for meeting basic needs. Our cafeterias at every hospital had converted into little mini marts for people to be able to do their basic grocery shopping as they leave their shift, so that they don't have to worry about getting the basic groceries and being online at the grocery store, which was very helpful. And they also partnered with bulk grocery company to provide home deliveries as well, in addition to that. At UCSF, also there's various webinars on the topic of well-being, psychological first aid, stress first aid, mindfulness, deep breathing, how to work with stress, parenting during the pandemic, so that employees can tune in at their own time, watch these webinars. They're archived, and so people can watch it whenever they want and access these as a level of universal support. On the next bucket that Chiari talked about was, if you can move the slide, was that supplemental support. And this is now one level up from just being able to watch webinars. And this can be, the examples are many. There's at Northwell, we're calling them Team Lavender, which is basically a rapid response team that can come to any time, responds like a rapid response team within an hour of being called, and has various members from social work to security to chaplains to psychology to psychiatry. Whoever is on it comes and supports that team or that team member in real time. We also are running various support groups for the different teams. And these are, for example, can be the ER teams that are at the front line, or the COVID teams themselves, but also specific groups that we have been running at the Children's Hospital for pediatric subspecialists that have been deployed, because again, their issues and their traumas are quite different from somebody that is working there at the baseline. Being redeployed brings with itself a lot of additional stress and different anxieties. So that group has their own support groups to tune into. We also have a 24/7 emotional support resource center, which anybody can call. That one is staffed together with employee assistance program and the employee wellness team, as well as the behavioral health service line, who provides social workers, counselors, and supervising psychiatrists. So people can call, get real-time support on the phone, and also provides linkage to ongoing care when that is needed. And one can also call a chaplain and schedule a heart-to-heart phone conversation and get that spiritual support going. So again, different levels of intensified support. And then the last bucket is the intensified support, which is actual clinical care. So we have a Center for Traumatic Stress that provides psychological first aid or stress first aid, which the two are a little bit different because psychological first aid was developed to be provided after a single traumatic event, whereas stress first aid was developed by the military, and it is meant for ongoing stress like the one we're experiencing now, where it's not one single event, but you are providing support to somebody who is still in that trauma, who still ongoingly goes back and continues to work in that stressful environment, and addressing sort of those type of injuries that Kiari also mentioned, the grief reaction, the traumatic reaction, the moral injury, feelings of guilt, feelings of not being enough. Are we doing what we are needing to do? Are we meeting the needs of our patients? And just sort of wear and tear of being exhausted while we're going back ongoingly to provide this care. And then also at both of our institutions, the departments of psychiatry had put together specific care for employees and expediting therapy and psychiatric services to those that need it. And this is triaged for us by the hotline, but can be accessed in many different ways, as well as the COPE program at UCSF, which does about the same, triages people and connects them with the care that they need. So in summary, there's many layers of this support, and it is needed, and it's needed to continue this and keep it ongoing, because what we've seen with utilization at both of our institutions is that the utilization for the more intensified supports is actually not that high, which is understandable when we're thinking about the fact that people are still in the midst of this trauma. Many of them are not ready to access these services yet, not ready to talk, not ready to reach out for support. And so it is really important for everybody to recognize that this sort of supports and initiatives need to be provided ongoingly, even as we get out of the pandemic, and need to be supported on the long run. And back to Pat for questions, if we have any.
Yeah, thanks so much. Oh, we definitely have some. So one question that came up was supporting and educating staff, not only around the anxieties and concerns that have come up around COVID and coronavirus itself, but around the fundamental shift into virtual work, sort of this web-based platform, staring at a screen all day, and the fundamental isolation that comes along with that, and any pearls that you would have around those questions or those problems.
Kiari?
Yeah, a lot, I think that question really to me echoes a lot of the challenges that we had as we were talking about putting in place a lot of these supports and services, and a lot of the providers, were talking to people on the front lines via telehealth or teleconferencing technology. And so we have tried to help people put in place some basic, and this is, I think, of like the top part of the pyramid of like the basic physical needs for, getting what we at our institution like to call as three-dimensional experiences. And so making sure, because we are allowed to go, so if going for walks or doing things that don't involve looking at a screen, and, taking time to do your exercise, or making sure you're sleeping, or in other ways of engaging that don't involve always being in front of a screen, and reaching out to each other, whether it's through phones or talking to each other in ways that are still safe.
Another question that came through was about the stress response infrastructure itself. That right now a lot of the stress response systems are run by volunteers, volunteer physicians, volunteers from other departments. And the question is sort of how would that transition into a sustainable model, given that we don't know kind of the end date of what we're going through right now?
Yeah, so for us at Northval, again, the lucky thing is that we have a pretty large employee wellness, employee support network, even before COVID, that supports all of these initiatives. And currently they are supported by a lot of volunteer physicians, but there is good networks built in. We have physician wellness champions in every department that were developed way before the pandemic hit. And what I've seen in our response is that we're really tapping in and kind of beefing up those existing resources that are there. And I am hoping that because of that, because it was pre-existing before the pandemic, that it will continue to be able to be sustained. One simple thing, for example, that we started to do this week, it's connecting doctors, doctor to doctor peer support, is having people within the physician network be assigned a list of physicians to call to just check in. And those are not very resource intensive things. And again, really looking into what are the existing resources before the pandemic and how can they be utilized for this purpose and then continue to be sustained.
I would echo that, and what we have found is both from our utilization numbers that people are looking for and using peer supports, whether it's group or individual, way more than a lot of the other services, and hence kind of maybe what we are planning on doing is taking those peer support champions and doing some quick and brief trainings, whether it's trauma-informed care training or other ways in which we can make sure that they're supported in their roles so that they can continue to do this in an ongoing fashion in a more sustainable way.
Great. Well, thank you, Chiara and Vera, and a huge thank you to all of our presenters, to Dr. Carlson, to everyone involved in this fantastic program. And Dr. Powell and I are going to now sort of wrap up.
Great. Thanks to all the panelists. It's been a great wealth of information across a lot of hospital systems. And I think that we probably will want to see more of these, get a chance for more discussions. So I'd like to pause for a moment while all our attendees are still here to take a quick poll on the effectiveness of today's webinar and the potential for future forum. So, and after that, we'll jump back to my wrap up and a few more questions. And we're able to stay a little bit later if people want. So take a few seconds to fill out your form and they'll let me know when the polls close. Okay. And here's the second question. Would you participate in another virtual forum on other hot topics? All right, so just to wrap up, I'd like to get to a few key themes that we've discussed today. And all of us, our patients and ourselves, could have any one of these mental health responses to the COVID-19 pandemic and being socially isolated. Most of us, in fact, will be resilient, and most of our patients, well, maybe not our patients, but most people will fall in the resilient group. And then there's the level 2 worried well group. The group that, many of the resources that you just heard about will be reassuring to for information and provide some help at a minimal level. But there will be a group of people who develop new mental health symptoms. And then there are the group of patients that we have that will have their symptoms much exacerbated. For instance, if they have OCD or possibly for mania and social and psychosis who are more isolated. So, and then there are even those patients who are in the imminent risk group, and we have to address their needs. Next slide. Oh, I think I'm doing slides. Okay, sorry. So there have been a lot of special challenges for all of us as healthcare workers during this pandemic. There's a lack of information, how the virus behaves, the testing availability, what the testing really means, what the antibodies mean, because we don't have that correlation at this time to illness to antibody. What are the effective treatments? Will it recur? What are the risk factors? So we're all in the stage of, as we say, building the plane while we're flying it at 30,000 feet. So there's a lack of resources, which we're addressing. The enormity of the problem is something very different for all of us to face. And the patient safety and staff safety, including staff family, are in conflict here. So we have to be very thoughtful, and you've heard people talk about how to find true north in these conflicts and have ethical consults and all be thoughtful and address these in a slow and thoughtful manner. Our usual coping mechanisms are not necessarily going to work for us in this time, and the scale of the grief is quite different from anything we've faced before. We're pretty good crisis managers, but the duration of this crisis and the uncertainty and the unpredictability is something new for us, and so we all have to face that, and that is why you're hearing about the importance of managing our own well-being while we're trying to manage the safety and care for others. And the rapid changes to healthcare delivery, it remains to be seen which one of those are actually going to stick. There might be a silver lining, and a lot of more people might be getting mental health care as people realize the importance of mental health along with physical health. We've talked about the spectrum of the mental health coverage systems during this pandemic, and we have to cover everything from well-being to burnout to mental health symptoms to psychopathology to our acute needs. And our needs are going to evolve. We've already perhaps are transitioning from the initial acute phase to this intermediate chronic phase, and we will have a long road in the post-disaster recovery phase. So fora like this and being able to share all our information together is really important. AACAP's been a wonderful home during this entire time to provide information to people on how to help with their kids, our patients, our healthcare system. So we really appreciate what's been happening through AACAP. You can stay connected to us through a number of listservs. That several of the questions have been directed at that. Quentin's email box is going to be flooded here, but you can email at qbernhard@acap.org to join either the Emergency Child Psychiatry Committee listserv, which has more than 150 members, the Inpatient and Partial Hospitalization Committee, which has more than 100 members, and the Physically Ill Child Committee, which addresses mostly consultation liaison interests, has more than 300 members, but this is the time for medical physical collaboration, and that's a very important time. So we look forward. If you have other ideas for future fora, please email us at covidforum@acap.org. We just really want to thank AACAP and Dr. Carlson for hosting this virtual forum, and for Quentin for helping us make this possible, and all the committees and all the work that went from the panelists, who I hope will all pop up and I will pop off. And thank you to all the participants. There have been more than 200 of you during this time, and we know that that demonstrates your interest and your care to improve the life of our patients and our staff and trainees. So thank you very much. Maybe NASA, you want to pop up here? And I think we're out of time, but if people feel strongly, I think the panelists are willing to stay on and answer questions if possible.
So the question box is still open if people want to submit some more. We do have some questions that were left over that didn't get a chance to be addressed that sort of kept coming up. We started talking about some of them, but one question was, in this environment, in what we're going through right now, why would someone choose to do a 2-year fellowship in child psychiatry instead of going into virtual practice, instead of going straight out? What sort of recruitment methods are you using, both for medical students and for current trainees? And I don't know if Anik is still on. Anik, if you want to give us your opinion, that would be awesome.
I think a couple of things that we've done, it's been difficult because normally our normal processes when we have med students or residents rotating with us are completely disrupted right now. Utilizing the time we do have to maybe do extra one-on-one, almost like Zoom sessions with like some of your senior faculty or people that might spur a strong interest or line up with the trainees' interest, and trying to have them have increased opportunities for connection right now is important. I think the pulls of going right into practice, whether it's tele or in person versus doing a fellowship, I think are largely unchanged, right? I think those same opportunities to like go be an attending and make money versus do a fellowship are there. I think I know there's been lots of discussion in AACAP around and through AdPERT around changes potentially down the line to fellowship. I will kind of steer clear of that hot box topic right now, but I will say that I think this is a great opportunity for us all to be sort of reimagining our trainee experiences and how we can further engage them. And really, if you have a trainee that you think is on the fence about joining our wonderful field, this is a really good opportunity to try to spend some extra time with them or find some extra ways to engage with them. Our medical school training has all moved to virtual, and so we're working on doing virtual recorded lectures. It gives us a little less face-to-face time with them. So trying to get more interest involved in like the psychiatric interest groups in medical schools and things of that nature are going to be extra important as we continue to try to lure some of the best and brightest to our field.
Yeah, in New York, the New York regional organization, NICAP, continues to do events for medical students and trainees. So just this next week, we're going to have a virtual event for them. Normally, these events are in person, where we talk to them about how child psychiatry is the best field to be in. But we are continuing them virtually, and we're continuing to connect with all the interest groups. And, I think that is really important during this time. Students, actually, many of them have a lot of time right now. A lot of them are interested in helping and involving them in any way that they can help, whether through volunteerism or research or academic scholarly activity that right now they have the time for. Those are all good, important ways to engage them. And so I think that I encourage everybody who's working with students to do that, to reach out, to see if they have interest, if you have a project that they can get involved with, if there's volunteerism that's going on at your institution that they can get involved with. Our medical students volunteer to just start calling our difficult patients that are, very sick and, having a hard time. So things like that, I think, can be still very helpful.
I'll add one more thing is that in terms of silver lining, our medical school has sent all of our students home. So in terms of getting them remote exposure to things, psychiatry is actually something that lends itself fairly well to video visits and things of that nature. I'm not quite sure what the surgeons are doing right now in terms of getting their students exposure to their field or to procedures or things that might be enticing to try to lure someone to apply for residency. So I think we have to be very proactive in how we try to reach back out to these students that might have actually some extra time, which not a lot of medical students have, to take an extra look at our field and our subspecialty in particular. So I think we can use this as an opportunity to really try to enhance recruitment.
Yeah, I think oh, go ahead.
No, just to piggyback on what Anik said, depending on what software you're using, most of the software that we're using to see patients has the ability to do three-way video. So having supervised sessions with patients and still are able to be engaged in that way, the technology lends itself to it. Go ahead, Nas.
Yeah, no, I was just going to say, I think this unfortunate crisis has resulted in a dramatic acceleration in the use of virtual care in academic settings. And I think that the difference between some of the virtual care services that are provided outside of academic settings and what academic settings are doing around virtual care, that gap will close significantly. The other thing is, I think this crisis has also made us tangibly aware at a higher administrative level about the value of mental health as an essential service. I think a lot of us early on really saw ourselves as potentially moving away and kind of serving a secondary role in this crisis. And then it became very clear that we were critical both in the hospital and outside the hospital, both to supporting first-line care staff, but also how essential mental health is to the functioning of the hospital. So I think our trainees are seeing that, and it may actually result in the opposite. We may get more increased interest both in psychiatric residencies, but also fellowship training.
One other question that came in was, I think for for Bo, a little more granularity around the finances that are going on right now and how to support your department and your mission during this time when everything's shifting. I mean, a lot of elective services are just completely shut down. People are being laid off at one of the highest healthcare crises of our time. So how to work that?
Yeah, that is a very hot topic, and I'll do my best to answer that. I think, not to share specific data, but any hospital or system, there is going to be a financial impact from this. It's just what it is. We went from very high census, very high volumes in surgical settings, hospital settings, and those had a very large impact. And so kind of the best messaging that I've heard is, what can we do as departments? What can we do as hospitals to contribute to that deficit, right? We have in mental health and in psychiatry, we have this wonderful opportunity that telehealth lends itself very nicely to our world and our care. And so we need to start thinking outside of the box and kind of thinking about, where are those other opportunities? Can we have enhanced ambulatory services? Can we do virtual partial hospitalization programs? Me as a CL and an ED doc, we're starting to talk about a model of, can we take on a couple virtual partial hospitalization patients within our roles to support this kind of financial need, because all of the systems are going to be impacted, and I think we will have a nice opportunity to contribute to the positive side of finances future forward. And again, the opportunities, I don't even know what it'll look like. Every day something's changing. So I'm sure in a month I'll think back and go, wow, I didn't know that was possible. But it's kind of a unique and interesting time too. And we'll see where we can go with that. But I think if everyone uses the lens of, how can I use the resources in the setting that I am to contribute to that financial mission, I think everyone will kind of be making a first step forward in the right direction.
Thanks. Another question that came up, and it's a really interesting, thought-provoking one, is, for better or worse, a lot of the volumes are down, and the kids that we're seeing are having to sort of figure out with their families how to manage things outside of the hospital. And is there a way for us to take lessons from this, or to move forward with that, to increase the ability of patients to remain stable without utilizing the ER, without having to go into the hospital?
Yeah, I mean, I think that's a very interesting question. My clinical life is in the emergency department, and we have a behavioral health urgent care. And what we are doing is providing services for urgent care to patients' homes, so that instead of them coming into the ER, or instead of them coming into urgent care, we're able to see them in their home, same day, real time. And if things are, not working well, doing repeat visits every day if needed, to support them through the crisis, to avoid coming to the hospital. And I do think that that is something that I would definitely like to see stay as an option. It's going to be dependent on how the regulations change back, and how the relaxation of regulation changes or not. And I think that highlights a very important advocacy effort that we all need to do, because I definitely think that we all see the value of being able to do telehealth and being able to support patients at home. On our earlier virtual town hall through New York regional organization this week, we did have a partial hospital discussion, and they are operating their partial hospital here in New York through virtually, and doing Zoom groups and doing support and parenting coaching for families. And this came up as well, as how valuable it is for people to not have to travel every single day into the hospital to get that kind of care. So I definitely hope that some of this is going to be here to stay, because there's truly a value for many kids that can get, and not just in rural areas. Certainly in rural areas, we've known the value of this for a long, long time. but definitely seeing the value of many, many different levels. So it's going to be an important.
I see Gay coming, but I want to say one thing, that we've revised the Ask tool pathway for outpatient phone screening follow-up during COVID-19, and we will be launching that next week. So because the answer can't be go to the emergency department every time. So, which will be good maybe for the whole healthcare system in general down the road. But so stay tuned for that, and we'll let Gay have the final word here.
Well, I don't know that it's going to be final, but I wanted to echo what Vera was saying. I was going to add one more thing to it, and that would be, it would be really nice if we could somehow or another collect the data on the aspect that you're talking about. I mean, sometimes we've known what to do about certain things. We just weren't able to do it because you don't get paid for it or because the regulations don't let you do it. So it's not like a big genius to think, well, gee whiz, if I talk to the person at their home and, you know, calm it down there, maybe they don't have to go into the hospital. It's that nobody paid for it to have you go in the home. And, you know, so some of this stuff, it would be really nice if we could somehow or another collect that information. I do think the advocacy effort is going to be extremely important in this piece. I guess that was the one part that I wanted to be sure we seconded. It somehow or another collect the information of the people that you think would have, that you saved from an emergency room visit or an inpatient hospitalization. I think Mike Sorter had made a similar point and some other forum that making the phone calls to home several times keeps people out of hospitals and out of emergency rooms.
Yeah, so locate your local epidemiologists and researchers and pull them into this, because we definitely can track what's going on. It's a natural experiment for us all.
Anyway, I wanted to personally thank you all for an outstanding couple of hours. And you may have more to say, but I'm not going to say anything more, but just my personal heartfelt thank you.
Thank you.
Thank you. Marilyn, that leads into another topic that came up, which is about research and data collection and sort of how to take advantage of the opportunity sort of inherent in this, while we're all also scrambling to maintain our clinical responsibilities and you know, keep the ship afloat, while sort of looking at how we're doing that, and any changes that you've seen in research or topics that people are looking at, or any way that we can sort of capitalize on that.
Okay, Adi, you want to address that?
Yeah, yes. So, you know, I can talk about this from more the consult liaison side of things. I think that it's really important. I echo the importance of collecting data and looking at what we're all doing as we're trying to, you know, do this in a very sort of agile way. We can first, step one, collect what were the common practices, what did we all find ourselves doing, what worked and what did not work, and not stop there, but also as a second step, look at, you know, how effective was what we did, and, you know, not just that it worked, but was it effective? And so we are actually, through the listserv, collecting this database of service level changes and then patient level data from hospitals that has been shared on the listserv to start this process. And you know, one more thing finally I will add is, you know, one of the metrics that's equally important to collect as we think about all the lovely opportunities that telehealth really affords for psychiatry is equity. Because, you know, we are finding that as we are having these conversations, I have certainly run into families who either, you know, can't afford to talk for long times on their phone because they only have so many hours on their plan, or can't really afford to, they don't have great internet service, or, you know, and so I think it's really important to also collect that data to make sure that we are keeping health disparities and equity in mind, to make sure whatever solutions we come up with are, you know, work for a broad swath of people.
Right. So I did want to just address one question that came up earlier. Not all hospitals can go to all telehealth. So in our hospital, we have a mixed model for doing patients consults in person, as well as some by telehealth. And it will really depend, as you heard from Bo, about how much screening and testing is going on in your facility. And that will really determine how free you feel to be able to be in person. and safe in your institution. As to what Coyote was just talking about research, Anik mentioned the medical students. They all need projects. The residents who are not on service might need projects. This is a good time to involve them creatively in looking. These are somewhat chart reviews over periods of time, clinic review. So put them to work. I'll get them to help us get this data. You're on mute.
Sorry, I would echo what you said, Marilyn. We have a pretty decent telecapacity, but we still have a hybrid model. We really had to balance what services make sense to be tele and what services make sense to be in person. And we're balancing that with patient needs, volume needs, and as well as training needs. So to really strongly echo your point, systems really need to think about the bandwidth that they have and then what makes sense for staff and what makes sense for patients. So I just wanted to really echo that point.
Yeah, and in our system where there's still testing available and we know the patient's negative, the patients have been extremely thankful to have a visit from a clinician when their families can't visit and they feel really isolated if they have very chronic illnesses or have been in the hospital a long time. Even a visit from a psychiatrist is something welcome.
Well, I think sadly that's about all the time we have for today. Again, just a huge thank you to everyone for taking time out on a Saturday to discuss this really important and really critical topic. Thank you to Alex and Jill and Quentin from AACAP and Dr. Carlson and all of the panelists. This will be available after the webinar concludes, so feel free to download and to comment, and just thank you so much.
Take care.
Thanks, everyone.
Thank you. Bye.